Welcome to Health Impact Live Digital Health Talks. I'm Megan Antonelli, and I'm thrilled to introduce our guest today, Dr. Amy Boutwell. Dr. Boutwell is a true healthcare changemaker. As a practicing physician with a background in public policy from Harvard, she has devoted her career to designing and delivering whole-person healthcare, especially for our most vulnerable populations. Dr. Boutwell served as the first director of the Health Policy and Strategy at the Institute for Healthcare Improvement, where she designed and led a groundbreaking multi-state initiative to reduce hospital admissions. It's an honor to have Dr. Boutwell with us today to share her insights on shaping healthcare delivery to improve outcomes and lower cost. Please join me in welcoming Dr. Amy Boutwell. Hi, Amy. How are you today?
I'm great, Megan. How are you today?
Good, good. I have followed your work for many years through your work at the Institute for Health and Care Improvement. And I'm just so excited to have you here because I think it's a real, we've reached a critical time in value-based care. But tell me a little bit about, what initially inspired you to focus your career on redesigning healthcare and, your focus particularly on vulnerable populations.
Thanks. Everyone has an origin story, and mine goes back to my childhood. Actually, I was about a 10-year-old when the Ethiopian famine was happening in the mid '80s, and I remember at that point in time learning that while there was enough food in the world, the food wasn't able to get to the people who needed it, and that was just a perplexing and challenging reality for me to grapple with as a young kid. And so really, as I became interested in healthcare and becoming a physician, that abiding passion around how systems work and re-engineering systems so that the need is met is really at the core of how I've pursued my career. And naturally, systems don't work well enough for any of us, but in particular, a place to really see the impact of redesigning systems and improving systems is for the people for whom it is working the least well, which is vulnerable populations of a variety of sorts, right? So people with behavioral health and mental illness, regardless of socioeconomic status, people elders, regardless of socioeconomic status, and of course, people who live with poverty and other social stressors. All of these different types of groups are poorly served by our existing system.
Oh, wow. I didn't realize that. And, I grew up around the same time, and it was such a, powerful and impactful part of the shaping of our growing up. And I think, it's interesting now to see, the kind of that food as medicine movement coming in. I mean, certainly with all the social determinants of health discussion, and then food as medicine and how we can, really make an impact. And that brings us to sort of back to that, discussion of value-based care. What is value-based care? Tell me a little bit about how you, look at that and, sort of the value-based care outcomes and what the elements, we need to get there.
So, one, I work at a particular interface of that value equation, which I think is just really ripe for describing what we're trying to do in value-based care. So I work at the intersection of trying to improve care in ways that reduce costs, right? That's the value equation. And the clearest way to reduce costs is to reduce avoidable hospital use. It is the single largest fragment of the healthcare spending pie is hospital cost. And so that is really where I've worked since I was at IHI and designed the statewide strategy to reduce readmissions at the state level. And then since the Affordable Care Act passed, leading efforts to reduce what I now call recurrent hospital use, meaning ED visits, hospital admissions, hospital readmissions, kind of the full suite of reducing acute care use. And, it doesn't really matter what stat or study you look at. We all know that hospitals and emergency rooms are being used not for acute care. They're being used as a place where people go when they have needs, but not acute medical needs per se. Mm-hmm. So there's just a ton of opportunity. And that's the slice of the value-based care spectrum that I work in.
Right. That's great. I mean, I think that when we talk a lot about value-based care, there, obviously that's sort of where it started. That's where the policy impact has been. But there's, so much a spectrum of where we could see it impacting and having value. Healthcare loves our acronyms. And I know that you in your work have, developed a number of methodologies around this. Can you tell us a little bit about those and kind of where they fit into this continuum?
Oh gosh, oh gosh. Well, I love that. I love that intro. We love our acronyms. So yes. So over the course of my 15 years in reducing recurrent hospital use, I like to think of three primary methods that I've contributed to the field. The first is an acronym called the STAAR Initiative, and really that's just a strategy. It's a strategic approach to reducing readmissions, taking the state as the unit of interest. And the reason why this is important is because a lot of times we talk about models of care or roles and responsibilities and staffing models as if a certain number of nurses or case managers to a certain number of patients is the only question to ask. And the cool thing about the STAAR Initiative is it took that bird's eye view to how the system is functioning at a statewide level and identified actionable, meaningful, and impactful ways to align stakeholder groups to move in the same direction. So, that would be, obviously state policymakers, state data agencies, professional associations, industry associations, and frontline teams. So the key thing that came out of the STAAR Initiative, two key things. Number one was to not just look at one role type or one disease condition. We were looking at all. That was very powerful and very different at the time. And number two, it was it was to view readmissions in that example as a function of how the system was operating. And so again, that system engineering, systems-based approach. Okay, number two is the STAAR method. And this was a natural outgrowth from STAAR, where instead of the state, we took a population. The population in this case was a hospital, sometimes an ACO. And essentially, what I did with the STAAR method was the Agency for Healthcare Research and Quality gave me and my team a 5-year grant to identify the ways that the strategies to reduce Medicare readmissions needed to be adapted or modified to better serve Medicaid. Well, when 80% of all readmissions in the country are Medicare or Medicaid, if you can align a strategy that helps Medicare and Medicaid, then you have a whole population approach. So ASPIRE is a whole population approach, and it's an acronym for 6 parts of this comprehensive data-informed system redesign strategy. And the cool thing about the ASPIRE method is thanks to the CMS Partnership for Patients and many of the district initiatives at the state level, the ASPIRE method has been used by thousands of teams in all 50 states. So that's just been really exciting to be part of in my career. And then the final method that I'll just mention is every single population struggles to get population-wide results if they do not have an effective strategy for high utilizers. And so I call high utilizers multi-visit patients and MVPs. And coming out of work in a statewide initiative I did in Massachusetts, and then a statewide initiative for Medicaid in New York State, we have the MVP method, which is a differentiated care pathway specifically effective for high utilizers of the hospital and the emergency room. So that's the portfolio that goes from state to population to subpopulation. And my work just really fluidly moves in between those methods depending on what the job is to be done.
Right. So STAAR, ASPIRE, and MVP. I love it.
Yeah.
And that, I think it speaks to the years of healthcare that you've put to healthcare, that you came up with these acronyms that are exemplify that. And I love that MVP is not most valuable player, but multi-visit patient. So that Makes a lot of sense.
Yeah.
Excuse me. And then, around that, I mean, you mentioned, Medicare and Medicaid is where so much of the readmissions happen,
Yeah.
right? And, and that's what I've always said is, if you can fix it in Medicaid or Medicare, you can fix it anywhere, right? So when you look at kind of the work around reducing hospital readmissions, what are you seeing as the root causes? What do we need to address to kind of come around that? And I know it's different for both, populations and all of that, but, what are some of the main things you're seeing?
Yeah. First and foremost is what's missing is taking a data informed approach. Now, you might say, what? How's that possible in the United States in 2024? Sadly, it is the most common mistake I see organizations make is they jump in to an assumption. Oh, there's an assumption that we have to work on chronic disease. There's an assumption that we need to work on the transition from hospital to home. There's an assumption around that leads teams into starting at a particular interface instead of starting at looking at what I call the epidemiology, the actual data of who is in and out of the hospital, and what are those subgroups without pre-defining what those subgroups are or presupposing that we know. So a great example just came from last year. I was leading an initiative in rural Alaska among hospitals in rural Alaska. And, their job was to reduce readmissions. They wanted to reduce readmissions. And everybody has the same answer. Oh, hospital to home and heart failure. Okay, these are the two assumptions that have held us back. And I can say more about that. But I said, no. Before you decide what you're going to focus on, heart failure, discharges to home, take a look at your data. We came back 1 week later, and all 10 rural hospitals in Alaska in this collaborative had the same aha moment. They looked at the number one condition leading to the most readmissions in their hospitals: alcohol. So how can we possibly make progress if we are not looking at our data first and then designing our strategies accordingly? Now, they came up flat-footed, as all hospitals do when they look at data and they see something like alcohol is a major contributor to readmissions. But then we just ask, okay, so what's the root cause there? What would we need to do? What practices, processes, and skills do we need to have? And then we can build. We can build around that. And so I would say that when we think of a population-wide approach, which is predominantly Medicare and Medicaid, the number one thing is look at who's coming back with high rates, and then design your program. And for some reason, Megan, we're just not doing that on a routine basis across this country.
Wow. Yeah, no, that's so interesting. I mean, and I think it speaks a lot about assumptions, right? And the assumptions that we make in healthcare. I mean, I'd love to hear a little bit more about, sort of your thoughts around, why those assumptions are in place, and kind of what we can do. I mean, obviously the data
Actually,
approach
I'd love to jump in on that for a minute, because it's really where I hope my contributions to the field have been differentiated from those of others, in the sense of, why do these assumptions exist? This really comes to equity, to an equity issue. And there is a prevailing wisdom in quality improvement, population health, and healthcare operations, that we can only work on things we know how to help, right? And so Caucasian English-speaking people who have a chronic illness well understood, like heart failure or diabetes, feel like they are within a zone of influence. And I will say, I have worked with thousands of very well-meaning quality and population health and operational leaders. And there is this equity bias around impactable and what we perceive to be unimpactable. And for those of you who have read any of my posts on LinkedIn, you'll know that I phrase my work as anti-unimpactable. I do not believe that there's actually anything that is unimpactable. It's our bias around what we think we can and cannot do. But we can impact everything that I've come across in the human condition, and there's a lot more capable people out there than I am. So I know that we can have a readmission reduction strategy that focuses on people who are in and out of the hospital with alcohol-related issues. Absolutely, we can. Just because we haven't before doesn't mean we can. And so I believe that I know that part of why we are avoiding embracing using data and root cause analysis to develop data and root cause analysis focused strategies is because of this impactability bias that we have just in our operators. So education and skill development can help with that.
Well, I will say given that the name of our organization is HealthIMPACT, I didn't actually pay you to come on and say that there's nothing that's unimpactable, but I love it. And I think that it is that in healthcare, whether it's drug addiction, alcohol, these things that, and that really opens the book on social determinants of health, where it becomes, what is the purview of the health system and the healthcare organization to impact, the things that aren't traditionally within their, diagnostic codes, right?
Right.
So, but that is great, and such an important point around that. And, at the end of the day, looking at the data, which of course with our community, who's very focused on data and technology, but also listening to their providers and listening to the clinicians and their quality folks of what they need to look at, that the data tells the story of where they need to focus. So that's all really important stuff. When it comes to that, where, you're talking about collaboration between the teams, and getting, making sure that data gets in the right hands, tell us a little bit about what your experience has been working with all of these hospitals around, cross-continuum collaboration and what that looks like in practice.
So really, the link is right there where you just took us, Megan, which is when we look at our data and we understand the systems issues that are causing people in certain subgroups to come back to the hospital frequently, the very next thing we do is we ask, okay, so what resources exist? And goes back to my days in the STAAR Initiative, taking the bird's eye view. It's not what resources do I have. It's not what can I do in my box as a social worker, case manager, doctor in a hospital or in a clinic or with 2.5 minutes. It's what resources exist. So we take that bird's eye view in response to the data, and we say what exists. And that is the very beginning of cross-continuum collaboration. Because what we do is we give hospital teams or healthcare teams permission to say, you do not need to meet all of the human and social needs. You just need to know what your patients are experiencing and then form the partnerships and processes and collaborations accordingly. And so this started way back when the Affordable Care Act was passed and there was the whole Medicare readmission things. And we started in the STAAR Initiative states, we started the first hospital and skilled nursing facility cross-continuum collaboratives. And they would meet and they would talk about process and root causes of readmissions and working better together. And that was in 2007, I can't believe it, 2008. And just today, now in California, I'm launching another cross-continuum collaborative to bring hospitals and Medicaid community-based care management organizations. It's called Enhanced Care Management in Cal-AIM. We are doing the same thing, matchmaking between hospital teams and community-based Medicaid ECM teams, bring them together and start to co-develop processes where we can find people with needs and link them to services. So cross-continuum collaboration is the action step that follows from look at your data, understand what your population needs, and then release yourself from the sense that you or your team or your entity must meet all needs, and rather form those processes to link people to the organizations in the community that does exist, and that gets results.
And it sounds easy, but I get the sense from healthcare and from, collaboration in general that, it's hard to get there. And I think whether it's, certainly cross organization, which is, I think what you're talking about there, and bringing that in. Tell me a little bit about how you're working with those organizations to really, get them to change their mindset, to get them to embrace that kind of bringing, we talk a lot about, even with respect to social determinants of health, it's like asking the hospitals, the providers to do one more thing, right? So how do you get these teams to kind of say, okay, collaboration is going to help you, not hinder you?
Okay, it is, I'm only pausing because I don't want this to sound overly simplistic, but it is about articulating the win-win and the short-term energy that in effort that needs to be expended, but that the short-term energy in creating better cross-continuum working processes, which is something that can be done in 90 days, it pays off on the back end in terms of a more fluid and fruitful operating reality for both entities. So what do I specifically mean by that? I'll use the example in the CalAIM collaborative in California that I'm running right now. Hospital case managers and social workers every day are at the bedside with patients who have health-related social needs. And the most common stressor in their day is feeling that there are, quote, no resources in the community to help these people. And so they are taking on either Herculean efforts in trying to individually problem solve and mobilize resources and, on an individual level, which is exhausting, or they're throwing up their hands and saying, this isn't my problem, it's the system that's broken, and they're experiencing moral injury. And so on that side of the equation, we have a lot of need and a lot of work effort or a lot of burnout that's happening. On the community-based care management organization side, these are organizations that are otherwise doing cold outreach to people in the community, and their enrollment numbers are low. And their business models are not thriving because they are not getting the volume that has been expected, because we all know there's a lot of people with a lot of needs. But cold outreach is like the worst possible strategy, actually. And so when we bring a cross-continuum collaboration together to say, here's a setting that is saturated with humans with needs, and here's an organization that would like to serve more humans, it's a very clear win-win. Now, we're going to put in 90 days of effort to co-design a workflow that works for the hospitals and works for the community providers. And yes, I'm asking hours of their time to do that. But once the basics of that workflow are in place, it will not require that same time and effort. Obviously, continuous improvement and good, collegial relationships will need to be strengthened over time, but that's it. And it's the same thing I've done with hospitals and behavioral health clinics in the community, hospitals and skilled nursing facilities, as I mentioned, hospitals and ACOs in the community. So it's just cross-continuum collaboration does not exist until we build it. We need to put in time and effort to build it, but once we build it, it is a win-win for both parties.
Right. That's great. I mean, and I think that it's such an important message to kind of send to everybody in terms of that, it's the upfront work that then pays off in droves later.
Yeah.
around, you work in Massachusetts, Alaska, California, you've implemented these programs everywhere, at the local, state, and national level. Tell us about some of the unique challenges you've faced in doing so, and kind of where you think, there's opportunities at each level for moving this along.
Yeah, I think well, let me start in kind of in a middle phase. My my privilege has been to mobilize groups of teams, groups of organizations, whether that's in central Massachusetts or the entire state of Michigan, or the country, like with Vizient or other national organizations. It's always mobilizing a group of teams. And the reason why I wanted to start there, Megan, is because when we mobilize a group of teams, it is a very powerful catalyst to action to overcome the challenge at the individual organization level of, we don't have time, we don't have money, we don't have resources, we have competing priorities, we have too many fires to put out. So the worst place to work is at the individual organization level, because we can't get out of our own way. But when I work at this aggregator level, convener, catalyst, mobilizer, then teams are invited basically to join an initiative that's moving forward. And that has been so powerful. And I hope I never have to leave this particular interface, because it has been so powerful to overcome the inertia to change that happens at the individual organization level. So I think that the unique challenges are prioritizing and creating time and space to do change at the individual level. An antidote to that is state and national convening. Mm-hmm. Now, there's a lot more similar. Again, one of the neat things from having worked in rural Alaska to inner city Baltimore and everywhere in between, all day, every day for 15 years, is essentially I see that almost all the problems are the same. And we've touched on some of them, actually. And so maybe I'm a very simple-minded person, but essentially when I meet a team in whatever geography, with whatever payer mix, with whatever local richness of resources or poverty of resources, the organizational willingness to change is a universal question. The willingness to look at and respond to data, and the willingness to engage in cross-continuum collaboration are really foundational in any of these environments. And the neat thing is, I have, a bag full of stories I can think from rural Alaska, from Frederick, Maryland, which is suburban rural Maryland, to inner city Houston, where the first step for each and every single team, when we looked at our data and we said, who do we call, who do we know to be our community partner for behavioral health or substance use, everyone looks right and looks left and says, I'm so embarrassed, I don't think I know who to call. These are VPs of care management in hospitals. Mm-hmm. And what I coach them to do is just say, it's okay, let's Google it. Literally Google.
Right.
Substance use, Houston, Texas. Substance use, Frederick, Maryland. And we find the largest multi-service organization that comes up, and we call the executive director. And again, more similar than different, each and every single time, that executive director is thrilled to receive the phone call and could not be more delighted to start a collaborative relationship. And so that's kind of the space I work in, is helping teams know that, yeah, your organization has its own unique, history and resourcing and whatnot, but there's a lot more similar than different across the board.
Right. What would you say, I mean, when it comes to that, what that reason behind at the individual organization level that it's the change is hardest, is that just because everybody thinks they're so different and thinks it's so hard, but when they then partner, they realize that that they're together in this, or is it more complicated than that? Am I oversimplifying?
So I think that there's two things. So number one is uh, in number one is inviting operators, not executives. And so when in my work, I'm often inviting operators, managers of departments, managers of teams, people who have responsibility or accountability for achieving a measurable aim like a readmission rate or something similar. And those are managers and operators. And so when they are offered the opportunity to do better in their job, they will take it. Whereas if the request goes to the executive team, it's in the queue with, capital, capital improvements and, many other big, decisions and priorities. And so operational improvements pale by comparison sometimes. And so again, one of the things I've loved about the space where I work is, of course, everybody always needs their executive champion to support the work, but empowering managers and operators to make change within their operating environment to get better results. So that's one of I would say that's a lever that I have stumbled upon and happily support the mobilization of actual doers.
Right. Well, and I mean, I think always about, kind of you have your executive leadership and then the management, and then also, of course, the frontline clinicians. And I think when we think about value-based care and how, it's come from sort of the world of policy and how it's been translated to the organizations. And I think, as you said, it's like we've taken some assumptions and maybe not done the right things to address it and to foster it. But in terms of how you support your clinicians in that from the organization, are there lessons that you've learned around that in terms of even just communicating what it is and what it means? Because I think they have often looked at it as, again, another checklist or another thing they have to, adapt to. Are there, for those clinicians, a way to support them?
Yeah, for sure. This is one of the great things about being a practicing hospital-based doctor is, I speak the language of my colleagues, right? And so what I don't talk about is value-based care. You may be surprised. I'm a leader of some of the most initiatives that help with value-based care as anyone in the country, but I don't use that term and because what the frontline wants is better care for their patients. And that is a true north that doesn't fade and that is not difficult to communicate. And so, the why might be, why are we reducing readmissions? But really in terms of the front line, it is to harness those patient stories or those staff stories where, someone comes back and there's really no good reason. And we're like, this is such a waste. And we implicitly recognize that when someone comes back to the hospital where we are 24/7 nursing care, telemetry and ORs ready to go, and someone doesn't need to be here, you don't have to teach the front line that that's waste. And so that's really where the honoring the existing, wisdom and horse sense of the front line comes into play, and then just say, so let's create a better way so that this doesn't happen so much. And really it's not simplifying value-based care. It's really just prioritizing what we, maybe leaders, administrators, policymakers, say is value-based care, but what the front lines know is just better care. It's better care. And so that's a great interface for anyone who's listening, is just to connect with your clinicians and saying, what we're doing isn't working. It doesn't make sense. It's not efficient. It's not effective. Let's try to make it better. And we're going to make it better in ways that result in this outcome called people don't come back so very much. And that really makes sense to the tens of thousands of people that I've been fortunate to serve in my programs.
Of course. Yeah. Better patients, better care for the patients. Absolutely. So 100%. So we always like to talk about good things in healthcare and the promising opportunities. I think, as we've discussed, I mean, you've done such amazing work and there's so much happening. And I think this shift to data, this ease of use of data, also, turning around some of these assumptions. But what are some of the most, what are you most excited about as you look at the coming years ahead with all this transformation that's happening?
Yeah, I think that you've mentioned some at the beginning in kind of in our why around food as medicine and health related social needs and care coordination across the continuum. I'm excited about enabling technology, making this work better, faster, quicker. And what in particular I'm excited about is enabling technology to help foster highly reliable processes. So right now in programs, we have highly variable processes. We sometimes identify people with high needs, and we sometimes do something for them. And what we can do with enabling technology with regard to high reliability is we can always identify people, and we can always apply certain services and supports to their care, so that we always are driving a better process. So I am very focused on enabling technology, driving high reliability and reducing variation. The other thing I'm excited about with enabling technology is to reduce the time and work effort of the frontline clinician in doing all of the things we've talked about in this session together. So identifying people with needs, pulling together information from a variety of sources to create a profile of what the person is and is not receiving or is not eligible for, without having hours of social work, community health worker, case manager work effort go into that. We can take back so much time. If we can take back time for the front lines, then we will gain their buy-in in executing the process. So let's use our technology to reduce some of this information searching and gathering, some of this information around who is and who isn't eligible, what resources do or do not exist, so that we can package that up to not only doctors. We often think about serving physicians, but not only docs, but to our entire healthcare team, so that they can see a person, have information synthesized and presented to them, that then they can take that next step at the bedside with the patient and the family and their cross-continuum collaborators to make next actions happen. So I know that when we can use technology to do these things, we will get a lot better performance out of our healthcare system. And that's what I'm focused on, is the performance.
Yes, and a very data-driven approach to it, which I love. And I think, you really laid a very powerful roadmap for that. So I feel like I could keep asking questions and learning about what you're doing, because it's just so impactful and I love it. But thank you so much for joining us, Amy. Tell us a little bit about, how our guests can get in touch with you. I know there's hospital executives listening who want to know how you can help them.
Oh, sure. Well, I love it when people connect with me on LinkedIn. Just connect with me, subscribe to my newsletter, message me. I'm super open to meeting new people through that way. Also, of course, my firm is called Collaborative Healthcare Strategies, which is a mouthful, but you can visit our website, and really on the website, I mostly focus on the experience of patients, staff, and executives in how they have benefited from the programs that we've done together. And so that's a good resource if you're wondering, how does this work for people like you in your position.
Perfect. Well, thanks again, Amy. I look forward to connecting, hopefully having you at
Thanks.
an event sometime soon and seeing you around as you're doing some really important work.
Thank you so much. It's been a great conversation. Thanks for having me on today, Megan.
Absolutely. Let's give a big thank you to Dr. Amy Boutwell. As we've heard today, tackling our healthcare system's biggest challenge requires innovative thinking, a data-driven approach, and cross-continuum collaboration. Dr. Boutwell's systems-based approach offers a powerful roadmap for teams looking to make a meaningful impact. Thank you so much for joining us, and stay tuned for the next episode.